Hello everyone, this is the Shientist, and I'm going to give an overview of this important and hopefully sort of thought encouraging audio podcast on science looking at discrimination, ignorance, and health indentation. This is the final audio podcast under the molecular storm gauge, and um, this is another Storm Lobostics Productions. This audio podcast will end series 3. Um, uh, as always, or in the majority, um, uh, I'm going to bring about this perspective, providing a bit of an introduction, some contentions, some areas around sort of looking at this topic with a bit more of a discussion, and then a sort of a summary, and I will highlight a few references for further reading at uh, uh, at at uh, uh, at and after completing the overall understanding of this particular this audio and podcast. So what's it all about? The science looking at and exploring discrimination, ignorance, and sort of the health indentation. So as you know, our listeners, by now, hopefully, the perspective is gonna be coming from sort of a healthcare and health research sort of bases, and this is going to there'll be an overview from sort of a long-term condition perspective, and sort of in keeping with areas sort of a focus on sort of those health care conditions that sort of sort of around the area around sort of kidney care practice, and I will be sort of highlighting or mentioning sort of some of the works around the renal patient support group, or the RPSG, because this overview will kind of relates to some works that I have read in some of the research that the RPSG team have done, and I thought it was actually a very intriguing way of looking at sort of long-term conditions or areas of kidney care practice, and looking at sort of healthcare and seeing how it's sort of indented. So in the introduction here is thus. So patients with long-term conditions, they account for about 50% of GP appointments, so general practitioner appointments, and about 64% of outpatient appointments and about 70% of hospital bed days. So that is understanding that's come out from the Department of Health in 2012 in one of their reports. Around 70% of total health and care expenditure in the UK, or in England, in the UK, is attributed to people with long-term conditions. So again, that's understanding from the report by the Department of Health in 2012. People diagnosed with a number of long-term conditions are the most intensive users of health and healthcare services because well, unfortunately and fortunately, usually they have more complex healthcare needs or requirements than those people, or than those in the general population, and where general population health is concerned. So in this context, though, most people aged, for example, 65 and over have sort of comorbidities or multimorbidities, and in some regard, and I kind of want to ensure that that listeners have this sort of understanding that those going through long-term conditions, long-term health concerns, for example, and for example, again from the works of the works of the Renal Patient Support Group, the RPSG, where they've published or they've highlighted perspectives from pediatric and young people going through a long-term condition, and young adults, for example, going through the long-term condition around kidney care, for example. There is a little bit of a likeness between those going through those conditions and those who are, for example, sort of over 60, over 65, for example, because such individuals, such patients or patient cohorts, for example, would actually have could develop, for example, comorbidities in line and in keeping with those sort of similarities with those who are over 65, who might have, for example, during their lifetime, for example, have sort of nothing, hopefully would have nothing too detrimental around the aspects of their healthcare until, maybe after over 60 or 65, they do develop a comorbidity of some kind of primary health concern, and so therefore, that there is a likeness in that regard, and at least there is a sort of a mutual territory wherein their experiences might be shared, and etc. So most people over 65 and over have multi-morbidities or can have comorbidities, and although that might be the case, a Scottish study actually found that an absolute number of people with sort of comorbidities or multimorbidities is higher in those in those also aged under 65, and its implications for population as a whole can be viewed and seen as a sort of a burden on healthcare resources more generally, and that was published in a paper by Barnett and team in 2012. According to and sort of following on from that, according to Article 1 of the United Nations Convention on the Rights of Persons with Disabilities, and this is abbreviated as a UNCPD, persons with disabilities, and disabilities is different from long-term conditions. I'm sure listeners would be aware of that, and there are people who there might be individuals unfortunately facing both. They may have long-term conditions and they may have disabilities. Those who have this is a definition that's come out of the Article 1 United Nations Convention, the UNCPD, and they say that those who have long-term physical, mental, intellectual, or sensory impairments, which in interaction with various barriers may hinder their full and effective participation in society on an equal basis with others. So this was context that came out in the from the Article 1 United Nations Convention on the Rights of Persons with Disabilities, the UNCPD, in 2006, and so when just to sort of highlight on top of that, so basically what I want to get to listeners is basically where sort of using the definition here, and it's a direct quote from the United Nations in 2006, where they highlight, for example, having these different sort of potential hindrances. They are I mean, there's a perspective point I want to put on this, and that is, whilst these might be hindrances, they are sort of barriers, and they are there is a sense of impairments on those in that regard, but in that context, what the United Nations conventions or UNCP, I'm not sure if it was something that was part of their remit, but to understand, for example, a full and effective participation in society on an equal basis with others, to get a definition around that, and more particularly, would probably be important. So this then leads into some aspects around the contentions, and there are contentions around this. I'm going to read, kind of highlight now some aspects around contentions, but dropping in some 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 I guess biostats for everyone to hopefully kind of hopefully paint your own pictures of how this, you know, this kind of kind of um, uh, helps to relate numbers with the context. So between 2010, 2010 and 2030, 2030, it's been estimated that the number of young adults or younger people with learning disabilities, so so that's anyone aged between 18 to all the way up to adult life, and the the further part of being an adult, before sort of, for example, retirement age, in at least in how literature has focused that, between 18 to 64, will set to rise by about 32.2%, from around 220,000 to around 290,000. So that means there's three in 3 decades, in 3 decades, over 30 years, again, the estimated number of younger adults or adults with learning disabilities between 18 to 64 will rise from around 220,000 to around 290,000, and the number of younger adults or adults with physical or sensory impairments will increase from about from around 7.5%, from almost 2.9 million, 2.9 million to 3.1 million, and that was actually understanding and context that was in line with the United Nations, sort of relating to the United Nations in 2006, but this particular that context comes out of a paper by Snell and team, who sort of worked on looking at some of these projections, Snell and team in 2011. And furthermore, rates of disability are increasing due to population aging and increases in long-term health conditions or long-term conditions amongst you know, sort of other causes, and that's been highlighted in a report by the World Health Organization in 2013. So with that in mind, there are these general sort of biostatistics or biostats, so that basically it helps relate actual figures and with context of what we see out, for example, around us, in and around us, sort of on a day-to-day basis. And so the evidence is quite clear, in that most people in the general population will have at least or fall into one or two of these categories, and most of these, by the by, are kind of unseen. Like, you can't always see whether someone has a sort of a long-term condition, for example, or health complaint. Physical, obviously, they may, but it might be obvious. But nowadays, as you know, listeners, even with those who have physical impairments, there are sort of mechanisms in place and aspects of healthcare, sort of replacement healthcare sort of replacement therapies, or sort of um, uh, focuses where, for example, those with physical impairments, for example, can, for example, have um, uh, um, limbs that might have to be, that might be amputated, for example, or owing to a physical impairment or disability, etc. So that if that's the case, then they can have they have prosthetics, and so it's not as obvious in that context, um, and generally speaking, there's more people across age ranges and population health that will have sort of a mix between disabilities, physical disabilities, long-term conditions that are actually um, a mix between a mixture between seen and unseen, but perhaps um, more unseen than seen. So so as so those are so there's some contentions with regard to the figures, and it all the biostats, and basically uh, um, again, to try and understand full full and effective participation in society on an equal basis, is to see that really everyone's on the same level playing field, irrespective of you know what they have in aspects of their physical or their abilities, generally speaking. So in that regard, and in relating, I want to now highlight a bit more around this by way of discussion. So a central concern to both national and international sort of governments is trying to better understand how effectively support individuals and groups and sort of patients with long-term conditions and disabilities. For example, and I'll throw it out there again, as I have done in previous audios and podcasts. For example, chronic kidney disease or kidney disease. And again, having looked at the work by the Renal Patient Support Group, or the RPSG, who have like those who have CKD, who have increasingly have or at least can have increasingly complex health can have increasingly complexities around aspects of healthcare. And in literature, it is highlighted that as such, that they are referred to as a and those with particular long-term conditions, not constrained to particularly chronic kidney disease, but it aligns to those aligns to those who have long-term conditions more generally, and also this relates to those who also have disabilities as well, are generally referred to as, in literature, at least literature that's out there, to, in looking at aspects of healthcare and population health, for example, that they are referred to as a burden on healthcare services. And so there's context that comes out from a team, actually, authors, Black and team in 2010, and this has generally the understandings and what comes out of from research and literature relating disability focuses and long-term conditions. This has driven shifts in aspects of healthcare, population health, and actually focuses around public policy. Research by Stanswacker and team in 2012, and Stanswacker in 2000 and team in 2014, sort of highlight the more the general areas around this, in regard to how sort of in at least sort of where aspects of ensuring that the appropriate sort of if not resources, the appropriate healthcare requirements to both well, more to those who in and around general aspects of healthcare are kind of aligned with that focus, where I've mentioned in previous audios and podcast listeners, and that is that terminology which relates to public patient and public involvement, and so thus to ensure really that aspects of healthcare are appropriately addressed for the very individuals and groups and people who would otherwise be viewed as a burden on healthcare. So I want to highlight this context as well now, and it does kind of align with contentions as well, but it's part of the discussion here. One recent example of perhaps indirect yet sort of authoritative discrimination against those with long-term conditions and disabilities, specifically, was in a recording actually made during a fringe meeting at the conservative. It was a conservative conference actually, on the 25th of August 2014, and at that time the Minister for Welfare Reform, someone who was someone named called Lord Freud, he said this. This is a direct quote from that particular sort of fringe meeting at the Conservative Conference on 25th of August 2014, and this was actually in a sort of a tabloid and online sort of news feed around that time as well. the Independent. It was the Independent tabloid newspaper that published this context, and the direct quote is this: "Some disabled people could be paid £2 an hour rather than the full rate of £6.50 if they wanted to work." Now, Lord, and obviously times have gone forward a bit forward from then. Whilst the minimum wage might have increased from £6.50 to whatever it is at the moment, this is an example really of hierarchy and potentially authoritative. I guess again I use the terminology as I mentioned before, and that is that it's an example of perhaps indirect but authoritative discrimination, and obviously there is some underpinnings around potential ignorance as well. So Lord Freud's statement highlights obvious concern, and this also informs the views that have to become more informed, and that are not always those of that always surround the chronic those who are long-term conditions, chronically ill, disabled, carers or relatives, but more actually of those who look at aspects of healthcare from a top-down approach, sort of policy driven, and actually unfortunately, it wearies me sort of no end actually to say that this also can be the behavior of academics and health researchers as well, and unfortunately, because there is a mix when it comes to sort of those sorts of those sorts of sort of meetings, then what happens is that it's almost, apart from being sort of authoritative in one way or another, it's also absolute well, it's absolute travesty when really and truly where aspects of when those in the public general health general public use sort of rely on those in government and to ensure that the appropriate care is provided throughout population and health, when actually what they're doing is keeping or hoarding the best of practice to themselves in one way or another, and that's also authoritative. Obviously, I mean, all of this, I mean, the context that has been published and highlighted in the Independent in 2014, it's, of course, listeners, it's open to its own interpretation, but actually when academics and health researchers are involved in this kind of effort as well. Actually, it is a problem because the academic language and some of the writings and aspects that are sort of pinpointed to drive certain areas of healthcare and healthcare practices, for example, then also also have sort of a bearing on different impact in the way decisions are made as well. And so to also say, I also want to say that this is that academic language and academic sort of the way academics and researchers, health researchers and alike, and how they put context in put context forward so that the work is published, and it really is not representable and does not have anything to do with focuses around patient and public involvement. And so that's where then politicians and where policy, whether in the UK, for example, and whether more broadly, for example, they lack awareness and they cannot relate. So this is understanding additionally or retrospectively that comes out from a paper by Shakespeare and Watson in 1997. So the question is here now. A question that follows is what can we hope that is done differently, that could be done differently. So the main focus is that policymakers should perhaps be making more headway to support people with long-term conditions and disabilities, and to prevent and preclude discrimination and ignorance at sort of all levels. And in doing that, that means apart from for example, the focus around minimum wage and salary and all of those things, it also means that that everyone involved in aspects of healthcare and research, for example, and obviously those in government or in who have the ability to draw on policy and should focus on inclusion. There should be more diversity, and there should actually have, for example, actual patients who actually know patients, or even health professionals, for example, in and around aspects of healthcare. In and around aspects of policy, to make sure and really I don't want to use the word lobby because lobby is quite a disgusting, it's another word for a movement, and really there's so many movements in today's world that they're not actually doing anything that are beneficial or advantageous. They do, of course, highlight or raise awareness about specific focuses and where there are where there are indeficiencies and perhaps sort of where certain injustices may lie and may relate. But overall, it is about at least where aspects of healthcare is concerned, it is about absolutely about having those individuals and represent kind of being involved in aspects of policy, so that it's not only more representative, but also the academic language that is used is actually more inclusive, more involved, and not just about frontline, but about those sort of behind areas of healthcare practices that are, generally speaking, when quotes like this can be said and reflected on, for example, really and truly, those behind the scenes in healthcare practices, much like those who are, for example, going through long-term conditions and might have disabilities as well, would also stand the strain, or have the strain, where at least they are also negated. So what can be done differently? So apart from doing everything in whichever way that can be done to actually offset and preclude discrimination, sort of discrimination and ignorance taking place more generally, it is about ensuring that there is understanding around this in different aspects of healthcare, and that's actually a priority, or should be a priority, for health professionals in different areas, focusing around long-term condition groups, long-term conditions and complexities around disabilities, etc. And so and I'm sure listeners would be aware, for example, that and I think I mentioned, it has been mentioned in a previous audio podcast, to highlight that there are sort of those healthcare practitioners, frontline clinicians, for example, that are really heavily focused on sort of building their track records around and professional portfolios around attaining funding and grant and applications from certain organizational grant bodies, grant institutions, for example, which mean that if, for example, there is, even if work or research related to aspects of patient and public involvement, there is either a compromise, or there is a risk where those who are in those efforts and research, they are not including those individuals from more diverse backgrounds, or thus to highlight that, unfortunately, even those health professionals and healthcare researchers and academics are very unfortunately supremist in their own way, but they do that in that look slight, and also look very sort of natural, when it's everything that is unnatural. So everything where academics and researchers, and I have read in a paper, in one paper before, that about for example, what those who are privileged to have a certain amount of understandings about certain writings and research, for example, that those individuals have they have a sort of an important right to highlight these contexts, that context where sort of public and policy is important, would be important, because again, or just to put a sub understanding on what I've just mentioned about those there's health professionals and those academics and researchers who are doing research and gaining grant applications, etc., etc. The works that they do are also a hindrance on and barrier on health on the aspects of patient the patients going, or individuals and patients and groups going through disabilities and long-term conditions, because they strive and focus very much on what is referred to as socio-economic research, and that hinders and restricts sort of thinking to more of a sort of an algorithmic sort of level of focusing aspects of healthcare, and that is not representative really at all. So now I want to draw this all together with a bit of a conclusion. One thing that can be said from all of this, at least one thing can be understood from all of this, is that those with long-term conditions and disabilities, etc., and obviously those in from doing academic research in frontline practice as well. Everyone generally has been using social media a lot more, and perhaps more exponentially than at least over a decade ago. Particularly, for example, social media platforms like Twitter, maybe Facebook, and others. They represent about 20% of time online, and perhaps more than that. And understanding around that actually has been published by Nissan Wire in 2013. Not surprisingly, though, people with disabilities and long-term conditions, they do seek to gain understanding from colleagues and sort of peer-to-peer sort of support to help inform certain aspects of healthcare, and also inform shared decision making. And social media offers advantages over standard forms of interaction as well, and has a sort of broad accessibility, immediacy, and offers opportunity for those who are looking to get more understanding around different sort of entities, and obviously where discrimination and ignorance is concerned is, for example, where if for example we rely on sort of understanding that comes out from what's published online, in whether in tabloids or in on social media or on just on for example, I don't know, known sites such as Wikipedia or anywhere really online, just around anything that we refer to, then there is this problem where, or this issue or conundrum whereby we take that as law, or is used as law, and we're not unfortunately we do not question, we're not questioning we're not questioning why that is being said. So this is also why, looking at the literature that's come out from, for example, the focuses around the renal patient support group, which have looked mainly around, focused more around this particular topic, but again, looking at it from those from long-term condition groups and actually those in with disabilities, they've sort of made a strive to kind of put context in, kind of ensuring that understanding can be more sort of formal, but also a sort of formal directive, and at least also representative. If you want more understanding around sort of what advantages there are for and sort of practices, for example, around social media use, Nissan paper in 2013 is quite a good one, and Timimi and G in 2009 and Timimi in 2012 also sort of are good examples of that. There is another report about patient and public involvement and online uses of online aspects of data collection, etc., etc. It was published by Involve in 2014, and that's also quite a good paper publication, a good kind of framework to get an understanding of how sort of social media can be used for investigators and researchers. But I mentioned this in here in this way, dear listeners, because that's not going to come out from anyone who's doing research in academia, in aspects of academia at the moment, and it certainly won't come out from anyone in driving aspects of healthcare policy in government, for example, and that's what I'm trying to get to, or trying to highlight as well. There is indifferences in sort of, if not mindset, also how again where the Independent in 2014 highlight that work, and highlight how that disabled people, which also can encompass those with long-term conditions and vice versa, could be paid £2 an hour rather than the full rate of £6.50 an hour if they wanted to work. Well, the thing is, whether someone has a disability or a long-term condition, and they want to work, and they want to do, carry on with aspects of their research, aspects of work, whether that's in academia or research, or practical, around practical focuses, then they should have the exact same opportunity as everyone else in the general population. So the so there's that understanding to be had as well. And for example, those in policy, or looking at it from a top sort of obviously the reason why people are looking at it from a top-down approach, or why things are top-down or hierarchical, is because things like the framework that came out of Involve, and though it's a very generic framework and document about patient and public involvement, and also use of social media, and how researchers, investigators can use that in aspects of healthcare research, as kind of um, uh, basically those in government, for example, will never look at that, and those who are academics and researchers that might also be might have some focuses around government as well, they will never look at that. If they do, it's not going to be to it will not be used in the way for inclusion and diversity. It's more about how to sort of get, for example, get more votes to get certain ideas and ideologies through population to implement in and around the population, and obviously population and society. So so there's Nisenwald paper in 2013, and Xi's paper in 2009, and Timimi's paper in 2012, all quite good. The use of information communication technology and highlighting the challenges of living with a long-term condition or disability, and that understanding through use of social media is important to most individuals of patients, because many want to be sort of involved to prompt issues where there is ignorance and discrimination, and that stands to be an ongoing, or can be an ongoing contention, and there are contentions around that, obviously, but they can also be generally overwhelming. And some of that context came out retrospectively from the Coulter and Collins report in 2011. I think that was the report, listeners, that related to, I think it was the King's Fund report, where Coulter and Collins focused on no information about me without me. Excuse me. And then and then there was information there also was about all information communication technology and sort of social media interfaces are potentially helpful and should be prompted to preclude discrimination and or ignorance. However, acquisition of knowledge and sort of alone is unlikely to be sufficient to motivate behavior change, and that's been highlighted by De Silva 2011. And this is why in sort of the Shientist series of audios and podcasts are there to kind of highlight, at least in aspects of healthcare, health service, and health sort of health service research, that from aspects of healthcare, it should be about providing or at least like to think that there's a focus around encouraging to sort of whatever the topic and focus is that individuals, researchers have, don't make it about a movement and having a group, etc., etc. It should be about getting the evidence correct, having it sort of contextualized so that the works are can actually stand to form, for example, a sort of a peer review publication, and that can sort of consolidate and sort of focus on some of that, the acquisition, a link between acquisition of knowledge, understanding, to also then represent aspects of change, aspects of what should, aspects of what should and should be done versus what needs to be negated, so that so that things can actually be done in a more prolific effort. And these are things that can offset that effort. The effort should also help preclude discrimination and or ignorance, and much like health literacy, for example, for anyone to become health literate, or wants to know aspects around their healthcare and maybe not in tune with not in tune or in line, is not really sort of into aspects of healthcare. Just like when health literacy becomes an absolute necessity, that is when patients and for example then potentially look to navigate and want answers to particular questions. Much like that, this is about ensuring or encouraging, really, that the acquisition of knowledge should be sought by not only just sought but also evidencing your own practices, so you stand to develop and basically acquire a sort of a mindset that either tolerates or just sort of it tolerates, but also is a mindset that is more of a collaborative than anything else. Interaction sort of can help ongoing challenges and where people may feel pilloried, but awareness also needs to come. Awareness and understanding around around those topical issues and focuses around long-term condition groups and disabilities, for example, should come from a bottom-up approach. Thus that should constitute really the whole patient and public involvement effort for future initiatives and even areas of policy, public health policy, for example. Social media have been used more so now, perhaps because more so because of the aspects around remote working or remote having focuses more remotely, for example. In this context, there is because of the what happened in COVID-19, the pandemic, 18 months to 2 years, where people were doing more things through, for example, online or through Skype, through Zoom, through MS Teams, etc., etc. Social media use would have also sort of increased, and that also included, for example, again, Twitter and other social media platforms. But suffice to say, again, using those alone will not help get answers. It is about whatever the question is, about doing the research and, again, evidencing. However, overall, there needs to be there probably should be. I don't want to say culture change. I don't want to say behavior change. I don't want to say anything that relates to or prompts where any of this sounds almost where this sounds dictatorial, and that's not the case. Is to say that at least that there should be an effort by those who look to want real answers for particular questions, against particular questions, that they search out the questions by of identifying the appropriate publications, and helps to help them draw in aspects of healthcare, for example, or services around healthcare, at least in this context, from what I'm speaking about, communicating. And this needs to be this sort of should happen. It should be encouraged, because lifestyles, if not lifestyles, then general healthcare can be affected from those who are going through such sort of ordeals or travesty, and so yes. So the final thing I want to say on this, as part of the conclusion, really, is if policymakers are potentially discriminated at top down level, then what chances do people have at bottom up? That's the question for everyone. And the answer, I've sort of highlighted that it is about documenting those evidences, and actually having work on in sort of almost publication formats, so that it brings that understanding to in one way or another, and making it more representative, so that those at top level really do understand what's happening at sort of all levels, really. So that then overall there does need to be more of a, there should be more of a this should prompt and encourage a more representative stance on a world which is shielded, isolated, and sort of has been also locked down. So that's the end of this audio and podcast. I will highlight a few resources for further reading, and listeners can check these out at their own time. There's a paper by Anderson and Litkens in 1999, and it's titled "Preferences for Equity in Health Behind a Veil of Ignorance," and that was actually published in a healthcare journal. And there's a paper again by I think I mentioned this in a previous audio, but it is quite a good one, so I'll mention it again. A paper by Barnett and team, Epidemiology of Multimorbidity and Implications for Healthcare Research and Medical Education, and that was a cross-sectional study, and that was published in the Lancet. There's a paper by Black and team. It's quite a popular paper apparently in and around areas of kidney health practice, and it's the full title of this particular paper publication is Early Referral Strategies for Management of People with Markers of Renal Disease, and it's a systematic review of the evidence of clinical effectiveness, cost effectiveness, and economic analysis, and that was actually published in a health and also in a healthcare journal. There's a paper by Clement and team in 2011, disability, hate crime, and targeted violence and hostility as a mental health and discrimination perspective, and that was published in another healthcare journal. Publication by the Department of Health 2012 is titled Long-Term Conditions Compendium of Information. It was a third edition, and that was again published by the Department of Health in 2012. There's a paper by a publication by the Health Foundation actually. It's by D. Silver. The author was D. Silver in 2011, Helping People Help Themselves. If you put those words into your search engine, that should be downloadable. And there's a paper by Eddie Byrne in 2000. It's a little bit dated, but it's quite a good one. Assistive technology and students with mild disabilities, focus on exceptional children. And then there's Eddie Byrne in 2004, measuring assistive technology outcomes in reading, and it's in a journal of special education technology. And Eddie Byrne again in 2005, assistive technology and students with mild disabilities, from consideration to outcome measurements. It's actually a book chapter in a handbook of special education technology and research and practice, and that was in 2000. It's a published book in 2005, so it's a little bit dated, but it's quite good to get an understanding around that around that. There's a paper by Lewington and team in 2013, raising awareness of acute kidney injury, a global perspective of a silent killer, and that was published in the Kidney International. There's a paper by Mohammed and team in 2014 about the renal patient support group supporting patients with chronic kidney disease through social media, and that's by the published in the Journal of Renal Care. And the paper by Quinn and Degener in 2002, Human Rights and Disability: the current use and future potential of United Nations human rights instruments in the context of disability. And that was actually in I think it was part of a Geneva thing, a Geneva reference, sorry, in the United Nations in 2002. There was there's a report by Snell and team in 2011, projections of demand for social care and disability benefits for younger adults in England, and it was a report of research conducted for the Commission on Funding of Care and Support, and that was in 2011. I'm not really I'm not a big fan on that terminology around social care, but definitely the Snell paper does put some context, some writing into context, and it's quite a good paper that I wanted to signpost. There is a paper. Yeah, there is just two more I'm gonna read out, and that is there's the United Nations 2006. I made reference to it as part of the audio and podcast, and this is the United Nations Convention on the Rights of Persons with Disabilities, and that was actually in New York, and then that's in 2006, and then there's the World Health Organization, who published on Global Disability Action Plan 2014 to 2021, and so those are those two are pretty good reads as well. So that's it. That's the end of this series on the molecular storm gauge. This has hopefully been an exciting audio podcast for you to check out and listen to. This has been the Shientist, and I look forward to bringing more perspectives in the next series. That'll be series 4, and hopefully it will be just as intriguing as this series. This has been another Ztorm Logistics production. Thanks for listening. Have a good one.